Hi, I'm Laura Murphy, pharmacist and pharmacy clinical site leader at Toronto Rehab with the University Health Network. Today, I will be giving a presentation on motivational interviewing. I have no conflicts of interest to declare. The learning objectives for today's presentation include defining motivational interviewing or motivational approaches to interviewing patients. We will explain how and why people resist change. We will describe how MI approaches help people engage in the change process. And we will demonstrate the application of MI to interviewing patients on methadone maintenance therapy or buprenorphine therapy. MI is a collaborative, person-centered form of guiding to elicit and strengthen motivation in people. It has been described to me as a way of being with people and really becomes a part of how you interact with patients once you integrate it into your everyday interviewing skills. It is a set of clinical methods that can be taught and learned. Next, we'll move on to ineffective and effective patient encounters. This is to set the stage and show us why motivational interviewing can be helpful. While you watch the video and reflect on whether the pharmacist displayed concern for the patient, think about if they are right in their advice to them. Please click on the link to view the video. Motivational interviewing is evidence-based. It was initially developed for substance use disorders, but now with a focus on brief interventions in healthcare, we are aware of better outcomes through behavioral management of chronic diseases, which is an excellent opportunity to apply motivational interviewing. There is evidence for use of MI with patients in methadone maintenance treatment. This has been shown to increase treatment retention and time to relapse, increase rates of smoking cessation by patients, reduce concurrent drug and alcohol use, and improve knowledge and adherence to medications in chronic diseases, such as HIV, HBV, and HCV. There is also a growing body of literature where motivational interviewing is used by pharmacists successfully. These usually center around patient adherence and chronic disease management. Positive outcomes have been seen in patients with diabetes, rheumatoid arthritis, HIV, and multiple sclerosis, for example. Recently, there have also been inclusion of motivational interviewing communication skills in pharmacy curriculums in North America, including the new curriculum at the University of Toronto. Ambivalence is the coexistence of opposing attitudes or feelings, like a love-hate relationship towards something. Ambivalence is commonly defined by characteristic behaviors, including procrastination or inconsistency between the way people act and what people say or what they believe. Here is a change scale, where on the left, at 0, people may be saying things like, "No way, I'm not changing." Whereas on the right, all the way to 10, they would be ready and committed to change. Most people are right in the middle, especially if they are expressing ambivalence. This is where they want to change, but something is getting in their way. Some patient statements demonstrating ambivalence include, "I don't want to use again, but sometimes I'm so stressed and it's the only way to mellow out." Or, "Smoking is bad for me and I want to quit, but I've tried before and I felt like a failure." I will let you read the other examples. I want to draw your attention to the balance of pros and cons in these statements. Patients are often weighing these in their decisions to change or not to change. Resistant tend to be more overt and is easier to identify than ambivalence. It can be exhibited by arguing, raising voice, blaming, making excuses, being hostile, or potentially even ignoring. Patients who are disengaged from the interaction are sometimes the most difficult to reach, because it's easy to make the assumption that they are not interested at all in changing. What we need to remember is that they do exist somewhere on that change scale, just maybe closer to 0. And within each interaction with them, we can actually move them forwards or backwards on that change scale. Here are some examples of patient statements who are resistant to change. You may recognize some of these statements from patients in your practice. Though it is often frustrating to work with patients who are resistant towards change or who are ambivalent towards change, motivational interviewing gives us tools to approach them. Instead of wrestling with them or fighting them, as it is a natural human resistance when told to do something or not to do something, MI provides us with these tools to make it more of a dance during the conversation with them. We can take the example of patient education. Traditional patient education, as many of us learned, usually relies on external motivation. That might include scare tactics, arguments against what the patient actually believes. This can lead to things like inadvertent shaming or even judgment coming through in the conversation, and patients not taking away important information that may be helpful to them. Using a guiding style or a motivational interviewing style, instead it's suggested that these steps be followed. First, patients should be asked permission to provide them with information. Then you can provide a small chunk of information to them, and then check in with them to see how it fits for them or how it fits into what they already know or believe. From the MMT program standards and clinical guidelines, we know that a patient's ability to exhibit positive change is attributable to several factors. These include extra therapeutic factors, the patient's experience of the therapeutic relationship, which is a large proportion at 30%, their sense of hope and expectation for recovery, and also the provider's techniques and skills, which include motivational interviewing, as it is evidence-based at 15%. We can see that as the healthcare practitioner involved in their care, our relationship with them and the techniques that we use make up almost 50% of the ability for them to exhibit positive change. Next, I'd like you to picture a patient from your practice on methadone maintenance therapy or buprenorphine therapy. In case you don't have one in your mind at this time, I've put together a case study of Greg. Greg gives us an example we can keep in mind as we work through MI skills. He's a 34-year-old patient who comes into your pharmacy, and he started MMT 5 weeks ago. His past medical history is significant for opioid dependence, which includes oxycodone CR, and depression, and he's currently on methadone 70 milligrams daily and escitalopram 20 milligrams daily, for which he's had some sporadic refills for the last 3 years. His social history is significant as he is divorced and recently lost custody of his children. He's currently unemployed. He does not use alcohol, but he does smoke cigarettes. And he also reports a history of marijuana and ecstasy abuse in his teens. Greg has been seeing his physician weekly for ongoing dose adjustments, and from seeing him daily and monitoring him closely, you know that he has had no withdrawal symptoms, but ongoing cravings for opioids. And he's admitted to you that he still uses oxycodone from a friend from time to time just to take the edge off. His recent urine drug screens have been positive for oxycodone. He also reports that he's increased his smoking to 1 pack per day. To give you a little more background about Greg, he hitchhikes or takes the bus to your pharmacy every morning and waits for the doors to open to get his methadone dose. You find him to be frustrated most days and angry. We're going to move next to introducing the principles of motivational interviewing. This uses one of the first of many acronyms that we will explore today. The first principle is to resist the writing reflex. That is part of the problem with a lot of our traditional communication techniques with patients, is that we exhibit as healthcare providers the writing reflex. We will identify that as the problem. The ULE are the solutions to that problem. Instead of demonstrating a writing reflex or judging our patients, we need to understand their motivations. We must listen to our patients and show them that we're listening. And we must also empower our patients around health behavior change and adherence. The writing reflex is the urge to jump in or give advice, to direct patients and set things right. If this is done before connecting with the patient and understanding the person you're trying to help, it can have potential negative outcomes. Here are some examples keeping Greg in mind. If we were to tell Greg at this time, he has to continue with methadone treatment and stop using oxycodone. Methadone is safer than taking opioids off the street. We know that that sentence may have the best intentions, but because Greg is ambivalent, he may not be ready to do all or nothing, and this might make him feel ashamed. If we were to tell Greg, "You'll feel better if you keep taking your antidepressant regularly. Let me just explain how it works," making the assumption that if he knows the information that we know, he would make the same decision we do. Unfortunately, Greg may secretly not want to take the antidepressant because he's heard they cause erectile dysfunction. Without understanding his motivations, or giving him the opportunity to tell us when we can listen to them, we will overlook a key motivator for Greg. If we tell him that smoking will lead to more health problems later, that may backfire. Many people don't care about long-term health outcomes, or they know someone who's smoked well into their 70s or 80s without any health problems. That could lead to a major disconnect. Next, we will talk about motivational interviewing spirit. This should form the basis of all of your interactions with patients. It can be remembered easily with the acronym PACE. P stands for partnership, acting as a partner in collaborating with the patient and respecting and drawing on their expertise. Acceptance is about communicating worth, genuine empathy, affirmations, and support for the patient's autonomy. Compassion is acting benevolently to promote the patient's welfare, giving priority to the patient's needs. And evocation is eliciting the patient's own perspectives and motivation. When we went over the definition for motivational interviewing, we introduced a guiding style of communication. Within any style of communication, there are the core communicating skills of asking, listening, and informing. Let's explore these more in depth. Asking questions in a guiding style is eliciting change talk from the patient. It is really trying to get their story and invite them to share with us. It's not just asking how they are or what brings them in today. We want to ask to help us to determine, for example, where they might lie on a change scale. We want to hear about their ability to change, their reasons, and their need for change. We want to avoid the question-answer trap. This can be very routine and controlling. Often when we are taking a history, this might happen. It can sound like the pharmacist's agenda overrides and can be to the exclusion of listening during the conversation. Skillful asking often leads to asking more open-ended questions versus close-ended questions. Again, providing an invitation for the patient to talk. A little high-quality listening can greatly promote a healthcare professional's relationship with the patient and can take as little as 1 to 2 minutes. Patients often feel that you've spent a longer time with them than you actually have. Listening with a guiding style helps us to gather information to promote the relationship. We need to use nonverbals and become comfortable with silence, allowing the patient to fill that space. To show the person we are listening, we should offer them reflections and affirmations throughout. When providing information, as pharmacists, we have a common tendency to hit the automatic pilot and cover everything that we feel needed to be covered as counseling. This can be overwhelming for patients. Remember the suggestion for structuring patient education using the strategy such as chunk, check, chunk. Remembering to ask permission and check in with the patient to see how it fits for them. Often information can be less intimidating if presented as what other people do or what other people find helpful. As experienced clinicians, it's helpful for you to draw on that when educating patients. Finally, we will explore the communication micro skills of a motivational interviewing approach. These can be remembered with the acronym OARS: open-ended questions, affirmations, reflections, and summary statements. Open-ended questions again are in a guiding style, with the aim to elicit change talk. Some examples may include: describe a typical day and how your medications fit in. How important is it for you to stick with the MMT? Tell me how you feel about taking your antidepressant. Note these are common stems for open-ended questions that can be very helpful to practice, such as how, tell me, what, or describe. The one stem that we need to be cautious about is asking why. Though it often leads to an open-ended question, it can sometimes sound judgmental. Sometimes all people need are a few words of encouragement. Affirmations are statements that recognize client strengths. They must be done sincerely. They are not praising, but they reframe difficulties or concerns that a patient has experienced into a positive light. We should aim to validate the patient's experience and feelings, their efforts, and their intentions. Though affirmations seem simple, they are not always easy. Some examples of affirmations and validations may be: you've given this a lot of thought. You have been very committed to coming in every day for your dose. You have been a role model. It is difficult to give examples in general for affirmations, as they need to be specific based on what the patient is telling you in order to sound genuine. Let's practice. If a patient makes a statement such as, "My doctor took away all my caries. I don't know if I can keep doing this, coming in every day to get my dose," I might respond to them, "You've spent a lot of time coming here every day to rebuild your trust with your physician." This validates their effort and reframes it in a positive light. Reflective listening is proof that you are listening and hearing and understanding your patient. It challenges you to form a hypothesis about what they really mean and read between the lines. There are different levels of reflective listening. They can range from simple to complex. Simple and complex reflections can be illustrated by this picture of an iceberg, where the simple reflections are what are on the surface, what the patient is saying, or what their face is expressing. To reflect this, you simply need to hold up a mirror to the patient and either parrot or paraphrase what they are saying. More complex reflections are about the deeper emotions and hopes and fears that they are expressing. These are what are lurking beneath the surface and tend to be disproportional in terms of the weight that they will carry with the patient. Let's take an example. If someone were to say, "How I live my life is my own business," I might respond to them, "You don't think anyone should have a say in your decisions but you." By using a reflection here, I don't need to argue with the patient. I also don't need to agree with them. I just need to reflect. I don't need to argue with the patient. I also don't need to agree with them. I just need to reflect their meaning in their statement to connect with them. Reflections may be different depending on the listener. They should pick out one small part of what the patient is saying overall. Moving on to another example, if a patient were to say, "Just give me my dose, I just want to get out of here," you might reflect, "You're frustrated because we've kept you waiting," so that they know you are hearing them. You may reflect or make more of a summary statement based on all the observations you've made. This might sound like, "You have other important things to do. Coming in here every day and attending appointments with your doctor is costing you time and money to take the bus. It's hard having to come every day for your dose." Note how this is different. It ties several pieces of the conversation together and reflects it back to the patient. As just illustrated, a summary reinforces what has been said throughout. It checks your understanding of the patient's situation as a whole and can be used to link together the patient's feelings of ambivalence with any change talk that you may have heard. Our next video clearly illustrates these communication microskills in action. While you watch this video about an angry patient, try to pay particular attention to Dr. Marilyn Harry's use of the OARS communication skills. In summary, motivational interviewing can fit into your practice. It can be included in every interaction with patients. To start, identify opportunities to use motivational interviewing when you hear patients expressing ambivalence and resistance. Embrace the spirit of MI, or PACE. Try a guiding style and let go of your writing reflex. This presentation is an introduction to motivational interviewing. For more training, there are courses available through CAMH at this link. There are also events internationally held through the Motivational Interviewing Network of Trainers. Here are some additional references and resources. Thank you very much.